Hello student, a very good evening to all of you. I hope I am clearly audible and visible at your end. Just let me know whether I am clearly audible and visible at your end or not. Then we are going to start this session. Audible, visible, good evening, good evening, good evening. Yes, okay, great, great. So thank you so much for the confirmation. So now we are going to start the image based discussion in physiology. As you know that this image based discussion series is going on, and this series is mainly dedicated for the upcoming NEET entrance examination, NEET PG examination, right. So in physiology we are going to discuss couple of images which are important for your exam, right. So all of you, welcome to the class, very good evening. Volume a little bit higher, okay. It will be done, no problem. Thank you so much. Thank you. Which topic will be covered today? So this is an basically image based question discussion or image based discussion, you can say. We are going to discuss certain MCQs which are based on images, important images of physiology. Some of the questions I have taken from previous examinations, and some of the questions are new, and those images has been taken from Genong, because you know most of the questions will be based on Genong and Guyton, but particularly the images which has been asked in exam, they mainly taken from Genong, although few images are also there from Guyton, but most of the images they will take from Genong. So I have kept some of the images, important images from Genong also, those are new images, and some of the MCQs are based on the previous one, right. So with this intro, we are going to start directly the questions. So I will first show you the question, you try to answer, and then I will give you the answer and explanation. Should we group this with LRR? This is a supplement to LRR, you can say, okay. So the PDF of this session, the annotated PDF of this session will be shared after 1 hour of the session. So you can download the PDF and you can just quickly revise these important images just before your exam once again, right. So that is the main motto of this question. FMG, yes, obviously this is for FMG also, okay. NEET PG and FMG, there is no much difference nowadays in the, if you look at the question pattern. So obviously this is for the NEET as well as FMG. Already INI-CET is done, so it's not related to INI-CET, you can understand, okay. So now we are going to start the session. So first MCQs that is coming in front of you. So this is an old MCQs, and this is a very common images in physiology, you know, ki physiology without action potential is not possible, right. So the first images in front of you is based on action potential, and this is an action potential of the mammalian neuron. So neuronal action potential. So whenever you get this kind of images, the first thing I told you in every class is that the first thing that you have to look at the every images in physiology, that what is the x axis of your images and what is the y axis of your images. Although you are finding out that this is a typical action potential, but look at the x axis and y axis. So x axis here is the time and y axis is the membrane potential. Membrane potential means the resting membrane potential or the membrane potential which is changing, right. So first of all, if you look at this graph, so this graph, this pink color highlights, this is the typical graph I am showing you here. So this is the typical action potential graph, and I believe all of you know that the first flat portion of this curve, so here if you look at here, so this is the resting membrane potential of the neuron. If you ask me that why sir this is the resting membrane potential, so we all know that in case of neuron, the RMP of the neuron, the RMP of the neuron is how much? Minus 70 millivolt in and around, minus 70 to minus 80 millivolt. So minus 70 is the best answer, neuronal RMP. So if you look at this flat portion of this curve, if you look at the flat portion of this curve, this is basically cutting in between this minus 80 and minus 60 millivolt. So more or less this is minus 70 millivolt around, right. So this is the resting membrane potential. So this A is the RMP. Then after this A part, if you look at the graph very carefully, you will find out that after A, the point number B is marked, but between A and B, this portion of the curve, there is a little slanting upward direction. This slanting upward direction of this curve, this is known as the local potential. This portion of the action potential is known as the local potential. This is basically is not part of the action potential, but whenever this local potential, will cross the threshold. So, again a second information you have to remember, threshold voltage of neuron is minus 55 millivolt. Okay. So, this is minus 60 and in between this will be minus 55. So, this minus 55 will be threshold voltage. So, whenever the action potential will cross this threshold voltage of minus 55, then the actual action potential will start from here. Okay. So, point number B, you can say this is close to threshold voltage, but not exactly the threshold voltage. And threshold voltage means whenever you cross the threshold voltage, what will happen? The action potential will start, means this rapid upward direction of membrane voltage change followed by rapid downward direction membrane voltage change. This is the actual action potential. Whenever you cross this threshold voltage, the action potential will start, and in bookish language we call it as a firing of action potential, getting my point. So, the starting of the action potential whenever you are crossing threshold, that is the firing. So, here it is say point number A is the firing level. So, obviously point number A is not a firing level, point number B may be, but again point number B is not exactly the firing level, little above the point number B. So, suppose point number B is given as a firing level, suppose point B is given as a firing level, then I will not choose this as correct answer, I will check whether the other options are more correct or not, right. So, I will find out better option even if it is B also. So, point A is firing level, this is absolutely false, right. Second one, between B to D is the refractory period. Now, whenever you get a diagram of the action potential, right. So, action potential from here to here, whenever you get a diagram of the action potential, you know that the total depolarization plus 1/3 of the first 1/3 of the repolarization is the absolute refractory period. So, you know from your knowledge that refractory period of neuronal action potential is, one is the absolute refractory period and second one is the relative refractory period, you recall. Okay. So, absolute refractory period is what? Absolute refractory period is total duration of the depolarization, means from the beginning up to the peak, that is the depolarization, plus first 1/3 of the repolarization. So, from here the repolarization is starting. So, if you take the first 1/3 of this total repolarization, then that will be included in the absolute refractory period. So, that is why I told that it is the total duration of the depolarization plus first 1/3 of the repolarization is the absolute refractory period, and relative refractory period is obviously the remaining 2/3 of the repolarization is the relative refractory period. So, if I look at the diagram once again, so from B up to the point number D, this is basically absolute refractory period. So, option B is saying that between point number B and D is the refractory period. It is absolutely correct. So, this is absolute refractory period and this is a true statement. Getting my point? Okay. Now, option C is saying after point C, potassium channel closes. So, after the point number C, potassium channel is not going to close, potassium channel close will start later on. After point number C, the most of the sodium channel will start closing. So, option C is again a wrong statement. So, this is also false statement. And option number D, at point number E, the neuron is hyperexcitable. So, this point number E is an after hyperpolarization part. So, neuron is in hyperpolarized condition. So, here the neuron is never hyperexcitable. Okay. This is lesser excitable than normal also. So, this is also a false statement. So, as you can understand from this discussion that option B is the correct and this will be the answer of this question. Now, everybody tell me whether you get this discussion, whether you understood this concept or not, because I have seen that action potential is very common image in physiology exam, right, in physiology MCQ particularly, whether it is NEET or whether it is anything. Everybody, my health is good. Okay, I am doing good nowadays, absolutely no problem. So, LRR we have discussed this, answer you have given, most of you have answered given B. So, absolutely correct, very good, absolute refractory period, D to the next relative refractory period, okay. So, okay, very good, Okay. So, maximum permeability wala question I will coming to that. Okay. So, I believe you understood this. Okay. So, this minimum discussion is required from this image. Okay. Now, the next similar kind of image, same action potential. Okay. But here the question is different. Okay. Now, here the question you look at here, this is a new question. Okay. So, again action potential from a neuron is shown here, okay, but image is a little bit different, but I believe you will be able to appreciate here that this A is the resting membrane potential, then here the B is the local potential, and after B the action potential firing has started. Okay. So, this is the action potential, and if you note down here the A part, this is below the resting membrane voltage. So, we call it as an after hyperpolarization part. So, this is the after hyperpolarization part of the action potential. Now, your question is permeability of potassium is to permeability of sodium, the ratio between permeability of potassium and permeability of sodium, where it is maximum. Okay. So, this question is purely based on Guyton. गाइटन में एक एक्शन पोटेंशियल का इमेज देके रखा है और यहाँ पे ऐसे टाइप का क्वेश्चन देके रखा है, ठीक है. सो आई बिलीव दैट yes, okay. So, if you have listened my lecture, I have explained this point also in my lectures. Okay. So, I will discuss this with the help of an image. This image is taken from Genong textbook. Okay. So, look carefully this image first. Okay. So, first of all look at this black color line. So, if I trace this black color line, this is the diagram of the action potential. Okay. So, this black color line, this is the action potential diagram. Okay. Along with the action potential, the sodium permeability and potassium permeability is also showing here. Okay. Sodium permeability and potassium permeability, what is that? Permeability means how much sodium, how many sodium channels are open at different point of action potential, that will determine the permeability of sodium. So, more permeability, more number of sodium channels are open, and more potassium permeability means same for the more potassium channels are open, because the sodium channel, potassium channel, they are the voltage gated channel. Normally they remain in closed condition when the cell is in resting condition. Whenever the action potential is started, action potential is starting, and then only this voltage gated sodium channel and voltage gated potassium channel will open up. So, the permeability of sodium is shown here with the red color curve. So, if you look at the red color curve here, so this is the red color curve, follow this curve, follow this curve. So, this is the curve which is denoting the permeability of sodium, meaning at which point sodium channel numbers are maximum, that is here. So, initially the sodium channel open sodium channel numbers are very less. Gradually the sodium channel numbers are opening to a maximum level and reaching here. After that the sodium channels are getting inactivated very rapidly, and at this point almost all the sodium channels are inactivated or closed, right. So, sodium channel, they are, the property of the sodium channel is that all of you know that sodium channel in action potential, they are the very fast type of voltage gated sodium channel. So, they open up very quickly and they also inactivated very quickly in this manner. Okay. So, if the question is that maximum sodium permeability at which point, then your answer will be here. Suppose this is point number C. So, at point number C it will be maximum sodium permeability, or you can say peak of the action potential correspond with the maximum sodium permeability. But if you look at the potassium channel permeability, so the property of the potassium channel is that potassium channel are slow in nature, although it is a voltage gated channel, but it is a slow in nature. So, slow means the opening of the channel will take long time. So, it is taking very long time to open up. So, maximum number of potassium channels are open here, but it is taking long time. If you look at here, sodium channel are already open to a maximum level here, but potassium channel maximum opening is taking long time, and it is almost the mid part of the repolarization. So, if I ask you maximum potassium permeability at which point, your answer will be middle part of the repolarization, mid part of the repolarization. So, if I give a point number D here, so D will be the answer of this question. Okay. Now, if you follow this potassium permeability curve, then you can find out that potassium channel closure is also taking very long time. Okay. So, after maximum opening, channel closing is also taking long time. So, when potassium channels are open here, see, Sodium channels are already closed, sodium channels are already closed here. Okay. So, if the potassium channels are open, but sodium channels are closed, then if you take a ratio between potassium permeability upon sodium permeability, what will happen to your ratio? So, potassium channels are open, मान लो 100 potassium channels are still open, but sodium channel numbers are near equal to 0 because almost all of the sodium channels are closed. So, these numbers are just the arbitrary number, this is just for your understanding purpose. Okay. Suppose at this point here the potassium channels are still open, but if you look at the sodium channel almost all of them are closed or inactivated. So, if I take a ratio between potassium permeability and sodium permeability, I can understand 100 sodium potassium channels are open, but sodium channel opening number is 0. So, some number upon 0. So, what will be the ratio? The ratio will be infinity. Getting my point? The ratio will be infinity. So, at any point on this curve, look at this curve, at any point beyond this, at any point beyond this where the sodium channels are almost closed, but the potassium channels are still open. In this zone, if you take any point in this zone, so here potassium channels are still open, but sodium channel are closed. So, if you take a ratio between potassium permeability upon sodium permeability, then the ratio will be infinity. So, infinity means obviously that is the maximum. So, if I go back to the original question here, so you can understand that this after hyperpolarization part of the action potential, so this point number F, this is the zone where the potassium channels are still open, but the sodium channels are almost inactivated or closed. That means, if I take a ratio between potassium permeability upon sodium permeability, this ratio will be infinity, and this is which point? At point number F. So, this point number F will be the answer of this question. So, D is the correct answer of this question. Getting my point? So, all of you tell me whether you get it or not. But if I ask you a different question, that suppose rather than potassium upon sodium permeability, if I ask you P sodium upon P potassium, this is maximum at which point? Max at which point? Then what will be the answer in this question? Same question, but my question is different now. My question is now potassium, I have reversed this ratio. Potassium permeability upon sodium permeability की जगह मैंने बोल दिया sodium permeability upon potassium permeability is maximum at which point? What will be the answer in this question? Okay. So, all of you are trying to answer, very good. So, now we have to search a point where sodium permeability is maximum, okay, because if you look at this curve once again, so throughout this sodium permeability is maximum here, followed by sodium permeability is decreasing, and potassium permeability is gradually rising and then it is decreasing. So, I have to search a point where sodium permeability is maximum. So, this is the point where sodium permeability is maximum. At this point potassium permeability is there, but that is very low. So, if I take a ratio at this point, then the sodium permeability upon potassium permeability will be maximum. So, in this curve, this point number D, that is the peak of the action potential, will be the answer of this question. Getting my point? So, these are the two important questions that can be asked in future. This has not been asked, okay, yet. The ratio has not been asked. They have asked that where is the maximum sodium permeability, where is the maximum potassium permeability, and they have also asked the previous one question, but this question, this question they have not asked yet. So, be prepared for it, okay. Chalo. Very good, very good. Priyanka, Satish, machines and all, you have given correct answer, very good, okay. Chalo, next question. Now, the next question again a new question, a little bit tricky and a difficult question I believe. So, if you have read the nerve muscle physiology in a better way, then you will be able to answer this question, and again this graph has been taken from Genong. So, be prepared anytime this kind of question will be given in your exam, right. So, look at the question. So, this is from nerve muscle physiology particularly length tension relationship. Generally in my class I talked about detail about the length tension relationship of the skeletal muscle. And what is the length tension relationship? That is nothing but the relationship of the length of the muscle and the tension generated by the muscle. So, at different length, muscle produces different forces. That relationship is known as the length tension relationship. If the length of the muscle is less, then the force production of the stimulated muscle will be lesser. If you go on stretching the muscle up to a certain limit, the muscle will go on increasing the force production. That relationship is known as the length tension relationship. Okay. Now, whenever you are looking at the length tension relationship curve, the 3 curve has been given here, 3 curve A, B, C 3 curve has been given, and regarding this 3 curve the question is given here. So, I will first describe this curve first, okay, because you require a little understanding before jump onto the MCQ answer. So, suppose this is the x axis, suppose this is the x axis, okay, and this is the y axis, this is the y axis, okay. So, in this x axis and y axis, what I am going to plot? I am going to plot that what is the force generated by the muscle when it is stimulated. So, suppose we have isolated a skeletal muscle and you are giving stimulation to this muscle. So, what will happen? The actin myosin cross bridge will be formed, and because of the actin myosin cross bridge formation, the muscle will contract, and because of the contraction it will produce force. This kind of force production by the actin myosin interaction is known as the active tension generated by the muscles. What I told? Active tension means it is a tension generated by the actin myosin interaction within the sarcomere when the muscle is stimulated, that is active tension. So, if you imagine a diagram, suppose this is the 2Z line of the sarcomere, I believe you know the diagram of the sarcomere, and along with this Z line suppose these actins are attached. So, this red color of the actin, and in between suppose these myosins are here. So, what will happen? Whenever you stimulate the muscles, this actin and myosin will interact, the myosin head will interact with the actin, and because of the interaction the muscle contraction will happen, the contraction of the muscle will happen, and this contraction will produce some force or some tension. This kind of force or tension is known as the active tension of the muscle, right, active tension. If you look at the active tension curve of the muscle, so suppose the x axis is the length of the sarcomere and y axis is the tension of the sarcomere, then you will find out the curve of the active tension of the muscle is following a particular pattern. This is like this. So, the detailed discussion of this curve is not possible, but if you follow the active tension of the muscle, then the active tension will follow a typical curve, that is like this. Okay. What is the meaning of this? Meaning is that at very low length of sarcomere, so when the length of the sarcomere is very small, very shorter in length, suppose 1.6 micrometer is the length of the sarcomere, okay. In this condition, the force production by the muscle, will be very less. Then whenever you are increasing the length of the sarcomere gradually, look at my graph, I am increasing the length of the sarcomere gradually, means I will increase the length of the sarcomere gradually, increase means I am stretching the muscle gradually. What will happen? Initially the force production by the muscle will also increase. So, what kind of force? Active tension or active force. So, whenever you are increasing the length of the sarcomere gradually, the force or the tension generated by the muscle is also increasing gradually. That is the meaning of this first portion of the curve. Okay. Now, if you go on stretching this sarcomere again and again, one point will reach where the sarcomere is going to rupture. Whenever you are reaching that point, that you have stretched the sarcomere in so much that the sarcomere is stretched or rupture, then what will happen? The force production by the sarcomere will go on decreasing like this. So, this second portion, this portion, descending portion of this active tension curve, it indicate that actin myosin interaction is decreasing. Why decreasing? Because sarcomere is so stretched that the actin myosin is detached from one another, and we call it as a rupture of the sarcomere. So, initially if you go on increasing the length of the sarcomere, the force production by the sarcomere will go on increasing, then up to a maximum level it will go on increasing, and after that the force production by the sarcomere will go on decreasing. This kind of curve is known as the active tension curve. Okay. Understood? Give me thumbs up whether you understood this. Okay, you understood now? Everybody? Active tension curve you understood? Okay. Now, now apart from this sarcomere or the actin-myosin interaction, you know, muscle also composed of elastic tissues surrounding the muscle, elastic tissue surrounding the muscle. So, what I told, apart from the actin and myosin, muscle also contains certain elastic tissue in the form of muscle fascia होगा, okay? There will be certain connective tissue surrounding the sarcomere, the muscle fiber के आसपास में जो हमारा perineurium, epineurium ये सब होता है, covering, all these coverings, all these coverings on the sarcomere, they are basically the elastic component of the muscle. Elastic component. They are not responsible for this active tension, because I told you that active tension is the force generated by the actin-myosin interaction within sarcomere. But outside the sarcomere, outside the muscle fiber, there are elastic tissues of the muscle, like for example endoneurium, perineurium, okay, epineurium, all these coverings and the other connective tissue which are present in the muscles, they are part of the elastic tissue. So, whenever you stretch the sarcomere more and more, the elastic tissue is going on stretch. Elastic tissue is also stretched, because this elastic tissue, they are like a spring. Okay. So, if you go on stretching this elastic tissue, it is nothing but stretching a spring. So, whenever you stretch a spring, it will generate certain tension, it will try to recoil back, and that recoiling back force is known as the tension generated by the elastic tissue of the muscle. So, the elastic tissue which is present in the muscles, they are also generating certain tension because of the stretch, and this tension is known as the passive tension in the muscle. Obviously passive, because there is no contractile element here, there is no actin myosin here. So, this is known as a passive tension. Now, passive tension generation will be started at a significant stretch of the muscle. When the muscle is at very shorter length, suppose the muscle is here, the muscle length is here, muscle is very shorter. So, muscle is completely relaxed. In this condition, the elastic tissue will not generate any tension. But if you go on stretching this elastic tissue or go on stretching the muscle, a point will appear from where the elastic tissue will go on stretching. That is why the passive tension will be generated from the middle portion of this active tension curve, okay, and it is go on increasing like this. Look at this green color curve. What is the meaning of this? Meaning is that when the muscle is at very shorter length, the passive tension is not there, because elastic component, elastic tissue is very relaxed, fully relaxed. But if you go on stretching the muscle gradually, a point will appear. This point is almost with the peak of the active tension. From there, the elastic tissue will go on stretching more and more stretching means more will be the recoiling force, and this tension which is generated inside the muscle by the elastic tissue, this is known as the passive tension generated by the muscle, passive tension generated by the muscle. And if you combine these two tension, active tension plus passive tension, this is nothing but the total tension generated by the muscle. And if you look at the total tension curve, it will follow the pattern like this, it will follow the pattern like this, okay. So, this is the total tension curve, okay. So, total tension curve initially is following the active tension curve, because initially passive tension is not there. So, whatever is the active tension, that is the total tension initially, but later on what is happening, the active tension is decreasing, but passive tension is proportionally increasing. So, that is why there is a dip in the curve, followed by there is again continuous increase in the total tension. Why there is continuous increase? Because later on the passive tension is significantly higher. Getting my point? So, now you got three curves in the muscle length tension relationship. One is the active tension. How to identify that? It will be a dome shaped curve like this. How to identify the passive tension? It will start from the middle part of the dome and it will go on increasing like this. And how to identify the total tension curve? There will be a dip followed by there is continuous increase. So, this is the typical curve of the length tension relationship. So, now you look at here, okay. So, there should not be any problem in identifying this curve. What will be the C? What is C here? Everybody tell me. What is C here? I want to say, I think I want to check that whether you are getting it correctly or not. Why not muscle damage? Muscle will be damaged. Muscle will be damaged. In this experiment, if you go on stretching, the sarcomere will be damaged. After that, muscle will not contract fully. Okay. The damage will be there. That's why I told you that there will be a rupture of the sarcomere. And if you look at the curve between these three curves, one curve you are finding out that there is a broken portion, and this broken portion indicate this is the damaged portion of the sarcomere, and because of the damage the tension is going on decreasing. Okay, that is the damage. Yes. So C is the passive tension curve. Very good. So C is the passive tension curve. And how to identify the active tension curve and the total tension? Active tension curve, there will be a broken line or there will be a significant decrease. So this B1 will be the active tension curve, active tension curve. Okay. And this A curve, it has not been completed, but it will be basically after this there will be an again uprise, and this will be the total tension of the curve. Total tension curve will be always above the active tension curve. That is always identifying point. So now you try to look at the MCQ's options. So option A is saying curve A represent the total tension generated by the muscle when stimulated isometrically. So this is absolutely a true statement, okay, because curve A is the total tension curve when the muscle is stimulated. Okay. Curve B represent the tension generated by the unstimulated muscle. So curve B is the active tension. So can a unstimulated muscle produce active tension? Answer is no, because active tension means the actin myosin cross bridge has to be there, and when the actin myosin cross bridge will form if you stimulate the muscle. So this one is the false statement, not the unstimulated muscle. Okay, curve B is the active tension curve. Option C is saying tension generated by the contractile element are shown in curve C. So tension generated by the contractile element, that is the actin and myosin, that is which kind of tension? That is basically the active tension, and active tension is not the curve number C, the active tension is curve number B. So this is also a false statement. Okay. And option number D, the difference between A and C represent the passive tension. The difference between A and C represent the active tension, because total tension minus passive tension is the active tension. Getting my point? Okay, because I told you combination of these two is the total tension. So option number D is also false. So only one option is correct, and that is our answer, that is option number A. ठीक है? Okay, हो जाएगा ऐसे क्वेश्चन आएगा तो. So whatever I have discussed, this has been written here for your understanding later on, that when the muscle is not stimulated, that is the passive tension. When the muscle is stimulated, you first record the total tension, and from total tension you subtract the passive tension, you will get the active tension. Okay. So generally when the muscle is stimulated, both the total tension will be recorded first, and from total minus passive, that is the active tension. Okay. So I believe you got it. Okay. This is an important one, believe me. Okay. Next, again this is a new question, new MCQ, but I believe this question I have discussed in my previous session also, but those sessions are not there in the YouTube right now. Look at. So this is a question from CNS. From CNS, image based questions are lesser in number. Okay. So mostly the questions will be a single liner question. PDF after the session, I told you that after 1 hour, you just look at the chat box of the YouTube link. Okay, the in the chat box the link will be given from where you can download the PDF. Okay, PDF will be given, annotated PDF will be given. Okay, chalo. So here the question is, the following diagram is the firing rate. Okay, so whenever you look at the language of the MCQ ना, कभी कभी होता है लैंग्वेज देख के ही स्टूडेंट डर जाता है. ओके, लैंग्वेज देखो, फायरिंग रेट. सो जब भी फायरिंग रेट बोलता है, ओके, लाइक द फायरिंग ऑफ द गन, बट द फायरिंग इन CNS is action potential firing. Okay, this is an important phenomena. Okay, so firing of the individual tactile receptor when a fixed stimulus intensity, the recording C is obtained from which of the following receptor. Okay. Again, whenever you are looking at an image, first look at the leveling of the image. What are the level given? From the level, could you identify anything? First you try to do that. Okay. So, this image, the lower part of the image, this is the stimulus, okay, and the upper part neural spike train. Again देखो, spike train का मतलब कुछ भी नहीं है, this is the action potential. Spike train, spike potential, this is nothing but action potential. And नीचे जो देके रखा है, this is stimulus. What stimulus? If you look at the question, all the 4 receptor that has been given here, that is the tactile receptor, touch receptor, and in the question they also mention that it is a tactile receptor. So, the stimulus is a touch. Whenever you give a touch stimulus on your skin, there will be indentation on the surface of the skin. यही तो ना, touch क्या होता है? If you give touch here, so there will be depression on the surface of the skin, and that depression is a kind of mechanical stimulus to the receptor. So, all the tactile receptor, they are the mechanoreceptor. They detect the deformation of the skin, they detect the deformation of the epidermis and dermis of the skin. And whenever there is deformation, the receptor will be activated, because those channels which are present in the receptor, they will be activated in presence of deformation, in presence of mechanical stimulus. So, whenever you are giving touch, it is nothing but depression on the skin. So, suppose I am measuring the, hold on a second, suppose I am measuring the depression, okay, on the skin, that how much depression is happening. Okay. So, stimulus here, stimulus here, okay, I am measuring what is the indentation on the skin, what is the depression on the skin. Suppose the indentation I am measuring, initially there is no indentation, then the indentation on the skin is gradually increasing 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, and then I am holding this 4 millimeter indentation for long duration like this. Getting my point? How I am drawing this curve? So, what is this? This is 1 millimeter depression on the skin, followed by 2 millimeter, 3 millimeter, 4 millimeter, and then after 4 millimeter depression, I am holding this depression, holding this touch on the skin like this. Suppose this pen tip is touching my skin, okay, initially there is no depression, then I am gradually pressing the tip of the pen on the skin. So, what is happening? There is 1 millimeter depression, 2 millimeter depression, 3 millimeter depression, 4 millimeter, and then this 4 millimeter depression I am holding on the surface of the skin for long duration. Now, I am looking at that what is happening to the receptor and the neuron which is connected with the receptor. So, what is happening to the neuron whenever I am giving this stimulus? What will happen to the neuron? Neuron will produce action potential. The neuron will produce action potential because you are giving stimulation. So, this action potential I am going to record on this line, the action potential I am going to record on this line. So, initially when there is no depression on the skin, there will be no action potential. Look at here, look at my diagram. So, initially there is no depression on the skin, mean receptor is not stimulated, no action potential is appearing. But from the point where whenever I am causing depression on the skin, from this point what will happen? The action potential will start appearing, means the action potential will come like this, again the action potential will come like this, again the action potential will come like this. So, whenever I am increasing the strength of stimulus, whenever I am increasing the depression on the skin, what will happen to the action potential? The frequency of the action potential will increase more and more. More the depression, more will be the increase in frequency. That is why there is an MCQ in INI-CET, that how brain understand the strength of stimulus. More the strength of stimulus, what will happen to the action potential? The amplitude of the action potential will never change, the amplitude of the action potential will remain same, but what will happen to the frequency of the action potential? The frequency of the action potential will be higher. So, the tip of the action potential will be same, means amplitude will remain same, but what will happen to the frequency? Frequency will be more. इसलिए हम लोग बोलते हैं कि strength of stimulus is directly proportionate to the action potential frequency, getting my point, not the proportion to the action potential amplitude. Now, if you hold this stimulus for long duration. Look at very carefully. So, initially when I was increasing the strength of stimulus, the action potential frequency was rising. But now I am holding the same kind of stimulus, 4 millimeter indentation for long duration. What is happening? The action potential frequency is gradually decreasing. The action potential frequency is gradually decreasing. Why the action potential frequency is gradually decreasing? Because the receptor which was here, this receptor is getting adapted. Because of the adaptation of this receptor, what is happening? The action potential frequency is decreasing. Getting my point? I give this example in my every classes, okay, that suppose your girlfriend or your boyfriend is holding your hand. So, whenever he or she is holding your hand for the first time, you know that the touch is a kind of electrical stimulation. You will get a kind of strong stimulus that he or she is holding your hand. But suppose he or she is holding your hand for the last 1 hour. Do you feel the same amount of stimulus after 1 hour? Answer is no. Why? The same stimulus is still there, the touch is still there, but again you are not feeling the same amount of sensation. Why? Because the neuron which are bringing the sensation, the receptor which is activated, the receptor is getting adapted to the touch. Because of the adaptation, the neuronal frequency of action potential is decreasing, and whenever frequency decreases, the brain will perceive less amount of sensation or no sensation. This phenomena is known as the adaptation phenomena. So, suppose you have recorded this kind of scenario from 2 receptor. Okay, suppose I have given the same kind of stimulus in a different receptor. Okay, and in the second receptor, okay, the phenomena what I am recording here is that I am getting same amount of action potential, same frequency of action potential, even when I am holding the stimulus for long duration. Suppose in the second type of receptor, so the first one, this is type A receptor, and suppose this is B receptor. In A receptor, whenever I am holding this same amount of stimulus for long duration, the frequency of action potential is reduced, means adaptation is happening. But in the second receptor, even when I am holding the same amount of stimulus for long duration, the frequency of action potential is not decreasing at all. That means this receptor, the second receptor, is not getting adapted, or we say that this receptor is the slowly adapting receptor, slow adaptation of the receptor, and the first one is the fast adaptation of the receptor. That is why you know that whenever you classify the tactile receptor in central nervous system chapter, we classify the tactile receptor into 2 categories: rapidly adapting receptor or fast adaptation, and slow adapting receptor. Okay, rapidly adapting receptor or fast adapting receptor is also known as the phagic receptor, and the second one is also known as the tonic receptor. So, the slow adapting receptor is also known as the tonic receptor, and the first one is known as the phagic receptor. Okay, so whenever there is changes in the phase of the stimulus, like for example here the phase of the stimulus is changing, the strength of the stimulus is changing, the frequency is higher. Later on, the frequency is lesser. But in the second cases, whatever may be the phase of the stimulus, even if it is same stimulus for long duration, still the receptor is activated in same amount. That means that is a tonic kind of receptor. So, now you know the examples of this phagic receptor or fast adapting or rapidly adapting receptor: Pacinian corpuscles, Meissner corpuscles, and hair end organ. So, this first adapting receptor examples is Pacinian corpuscles, Meissner's corpuscles, okay, and the hair end organ. And the slow adapting receptor examples, you know, the Merkel's, okay, Merkel's disc, the Ruffini's, and the free nerve ending, So, these 3 are the slow adapting receptor. Very good. Okay. So, most of the things are done. Now, if you go back to this question originally, so now you will be able to appreciate that what is the meaning of this. So, this is the change of strength of stimulus followed by you are holding the stimulus for long duration. What I am finding out, that initially there was few action potential, later on no action potential. In the B, whenever I am holding the same amount of stimulus, the action potential is coming, but at a lower frequency. That means this receptor is a kind of slow adapting receptor. This is the kind of slow adapting receptor. The option D is also a slow adapting receptor, but C and A, this is also a fast adapting receptor, this is also a fast adapting receptor. Now, if I have to identify between C and A, I can understand that in C, how many action potential you are getting here? How many action potential? Only 3 action potential, followed by there is no action potential. And in second cases, option A, initially how many action potential you are getting? So, this single line is a single action potential. So, 1, 2, 3, 4, 5, 6, around 6 action potential. So, I can understand that C is more fast adapting or more rapidly adapting than even A also, by counting the number of action potential. C is so rapidly adapting receptor that after 3 action potential, no action potential is coming up. That means the most rapidly adapting receptor is the C. So, this is the most rapidly adapting touch receptor, and you know the examples of most rapidly adapting touch receptor in our body, that is Pacinian followed by Meissner's. So, in these examples, C is the Pacinian, B, A is the Meissner's, okay, and B and D, they will be Merkel's and Ruffini's, okay. So, Merkel's and Ruffini's. So, answer of this question, that recording C is obtained from. So, recording C is obtained from the most rapidly adapting receptor, touch receptor in our body, that is Pacinian corpuscles, and Pacinian corpuscle is the best receptor for detection of the vibration also. So, this is the exact images from where I have taken this MCQ. So, as you can understand here, so this C is the Pacinian corpuscle, this is the diagram which is given here. So, this is Pacinian corpuscles, and this A is the Meissner corpuscles, this is the diagram given, and in between you are getting the Merkel's. So, this one is the Merkel's and Ruffin is here, okay, Merkel's and Ruffin is here, okay. And this middle part, this is the receptive field of different tactile receptor. So, if the question is smallest receptive field is for which tactile receptor, smallest receptive field. So, you look at this image. So, this surrounding area, so this is the field from where the receptor can detect the touch. That is the meaning of the receptive field, that what is the area from where the receptor can detect the touch. So, if the question is smallest receptive field is for which touch receptor, look at the diagram and answer. Look at the diagram and answer. Smallest receptive field is for which tactile receptor? Everybody, Dr. Twinkle has given correct answer. The answer is the Merkel. So, this is the smallest receptive field, and because of this smaller receptive field, the Merkel is the best receptor for 2-point discrimination also, as well as the reading of Braille, okay. The Braille reading and the 2-point discrimination, for both the best receptor is Merkel's because of the smallest receptive field, okay. Whenever the receptive field is large, you will not be able to identify the elevated point of Braille, you will not be able to identify the 2-point separately, okay. So, this is all about the discussion of the MCQ. Got it, everybody? Okay. Next question. Next question is a repeat question from NEET PG. So, if you are preparing for the NEET PG, I believe you will be able to answer this question. So, this question is only based on the EEG diagram, and you know ki this is not a best question in exam. This is not a best question, okay. Only EEG, it is very difficult to identify the stage of sleep, okay. That is why the polysomnography reporting is there, and in polysomnography not only EEG, you know that the electrooculogram is also required and the electromyography is also required, at least 3 recording is required, but here only the EEG recording is given. Now, how to identify this EEG recording? So, what you have to do, always look at the x axis, okay, and in x axis time period is given. So, you know the frequency of different waves in the EEG, right. So, within this 1 second period, how many peak of the EEG wave you are getting? But if you look carefully in this diagram, so within this zone, the graph is like a disturbance in the baseline. So, whenever you are getting a curve which is looking like a disturbance in the baseline, that means this graph contain huge frequency of potential, huge frequency. Okay, that's why it is looking like a disturbance. इतनी छोटे छोटे peak होगा कि you will not be able to identify them separately, and that's why it is looking like a disturbance of the baseline. So that means there will be multiple peak within this small segment of 1 second. So if you are getting multiple peak, that means the EEG is a high frequency wave. So this is a stage of sleep where EEG is showing high frequency wave. We all know that this is only possible in only one stage of sleep, that is the REM sleep, because the REM sleep is known as a paradoxical sleep. The REM sleep is also known as the paradoxical sleep. Why paradoxical sleep? Because the person is in the sleeping stage, the muscle tone will be completely lost. But if you look at the EEG, EEG will show you beta like activity, beta wave like activity means high frequency wave, as if the person is awake, but the person is not awake. If you look at the muscle tone of the person, the muscle will be completely paralyzed, atonia of the muscles. That's why the EEG wave is not synchronized with the stage of the sleep. That's why it is known as a paradoxical sleep. So whenever you are getting a EEG which has high frequency within this 1 second period, that indicate that the person is in REM sleep stage. But as I told you that this is a bad question. You should give at least these 3 recording. What is the 3 recording? EOG, that is the electrooculography, electromyography and electroencephalography. Not only the electroencephalography, you also have to look at the muscle tone. So now if you look at these 3 diagram parallelly, then see here. So this is the muscle activity, this is electromyography, this is the muscle activity. Muscle tone is still there, muscle tone is still there. But if you look at the last diagram of the EMG, electromyography, then you are looking like only a baseline and few activity, very minute activity. That means this indicate that the muscles are completely paralyzed, atonia of the muscles, muscle are kind of atonic. Okay. With this, whenever you are getting a kind of paralyzed like condition, with this whenever you are getting a EEG which is showing high frequency, then and then only you will be able to comment that the person is in REM sleep stage, okay, that the person is in REM sleep stage. So, differentiation between this REM sleep stage and the other stage of sleep is that you look at the EMG. Typically, the EMG will be silent, straight line, almost straight line, that indicate REM sleep. And the other sleep stage, the EMG activity will be there because the muscle is maintaining their tone. What is tone? Tone is the partially contractile state of the muscle. So, some of the muscle fiber are still contracting, that is why the muscle is maintaining the tone, and that is why I am getting some activity within the muscles. Okay? And you know the different sleep stage has different EEG. So, if you look at this stage 3 and stage 4, nowadays this stage 3 and stage 4 in combination, they are known as the N3 stage, I believe all of you know. Okay, so, this is N2 and this was the N1 stage, non-REM sleep, right. So, in stage 3 and stage 4, within this 1 second zone, suppose this is 1 second zone, if you count the peak of this EEG, how many wavelet you are getting? 1, 2, 3, 4. So, the frequency of this EEG wave which you are getting here, the frequency is more or less 4. Okay. So, 4 means obviously this is a kind of delta wave. So, delta wave indicate that is the deep sleep stage, that is the N3 stage. So, by this wave, first you count the x axis, how many wavelets you are getting within this, okay, and then you look at the EMG. But even if the EMG is not given, okay, or even only the EEG is given, you can count the x axis 1 second period, that what is the frequency, what is the probable frequency of this wave, and then you can comment. But again I am telling you, only EEG is not the diagnostic of the sleep stage, but here the EEG is very typical of the REM sleep. Okay. So, REM sleep is the answer of this question. Okay. Next question. So, this is a very easy question, everybody should answer this question. So, this is from cardiovascular system, and if one image you have to read from cardiovascular system, the ventricular muscle action potential or the Purkinje fiber action potential. So, this is the action potential of the myocardium. So, this is the action potential of myocardium, or the action potential of Purkinje fiber. Purkinje fiber, both will have the similar kind of shape. SA node, AV node will have a different kind of action potential. So, this is a very easy question. So, this phase number 0, this is known as the depolarization phase, this is the entry of sodium, downward direction means sodium entry. The phase number 1, that is the transient repolarization phase, this is the exit of potassium from the cell. Then phase number 2 is calcium entry, okay, parallelly potassium exit is there, and phase number 3 is the exit of potassium is the main cause, along with that calcium channel will be closed. So, these are the 4 different phases of the action potential in the myocardium, and this phase 4 is nothing but the RMP. All of you know this by time. This phase 4 is nothing but the RMP. What is the RMP of the myocardium action potential? What is the RMP? RMP कितना होता है? Membrane voltage कितना? RMP of myocardium. Just now we have discussed RMP of neuron is minus 70. What is the RMP of myocardium? Minus 90 millivolt. ठीक है? Very good, very good. That is minus 90. From your name I can understand that you will be able to understand Riluzole. Very good. Okay. So, minus 90 millivolt is the RMP. Very good. So, good. Okay. So, now if you look at the question, so question option A, calcium channel opens in phase number 2. So, this is a true statement. Potassium channel closes in phase number 0. Phase number 0 is not related to potassium, so absolutely false. Transient sodium channel opens in phase number 3. Phase number 3 transient sodium channel is never an option. Calcium channel closes in phase number 4. Phase number 4 is the resting membrane potential, which is mainly due to the potassium channel, that is the leak potassium channel. So, this is also false. So, only one statement is true, that is option A, and that is our answer. Good. Okay. Next question, again a very pet question in almost every exam, and this thing I have discussed in multiple time in multiple discussion. So, quickly answer. So, I believe you know the pressure volume loop. So, pressure volume loop x axis is the left ventricular volume and y axis is the pressure change. Okay. So, quickly if we discuss from point number A to point number B, okay, point number A to point number B, between point number A, point number B, okay, this is what? This is nothing but the point A to point B. This is nothing but the filling phase of ventricle. This is nothing but the filling phase of ventricle. Okay. Then point number B to point number C, point B to point number C, this is the isovolumic contraction. Yes, everybody should answer this question. Okay. So, this is isovolumic contraction phase, isovolumic contraction phase, right? And point number D to A, point number D to point number A. So, this is the isovolumic relaxation phase. This is isovolumetric relaxation phase. Very good. ठीक है, ठीक है. So, now all of you know that the point number B is the end of diastole. Remember, end of diastole means at point number D, at point number B, whatever volume is present in the ventricle, that is your end diastolic volume. This 150 ml is the end diastolic volume in this diagram, right? 150 ml. Then from point number B, the ventricle will start contraction, and at the beginning of the contraction, this point number B, there will be closure of the, so whenever ventricle contract, what will happen? The tricuspid valve and the bicuspid valve will closed. That means this is the point where the first heart sound will be produced. Okay, first heart sound will be produced. So, this point number B is the point where the first heart sound will be produced. Then the ventricle will contract isovolumetrically. At point number C, there will be opening of, okay. So, point number C, there will be opening of semilunar valve, right, aortic valve or pulmonary valve will open up. Then there will be ejection phase. So, this C to D is the ejection phase, okay, ejection phase. After the ejection, at point number D, what will happen? The isovolumic relaxation will start. At the beginning of the isovolumic relaxation, there will be closure of the semilunar valves. So, this is your second heart sound. Very good, very good. So at least PV loop you know, that I can understand from this discussion. PV loop बहुत अच्छे से आपको पता है. Very good, very good. Okay. So this is the second heart sound, and then this is the isovolemic relaxation. At point number A, the ventricular filling will start. Ventricular filling will start whenever there is opening of mitral and tricuspid valve, atrioventricular valve, AV valves, right. And between the point number A to point number B, what I told that this is the filling phase of ventricle. During this filling phase, you are going to get the third heart sound also, as well as you are going to get the fourth heart sound also, because we all know that third heart sound correspond with the first rapid filling of the ventricle, and fourth heart sound correspond with the last rapid filling phase of the ventricle. Last rapid filling phase is caused by atrium contraction. That is why there was an MCQ that atrium contraction contribute to which heart sound. Your answer will be fourth heart sound. So, third and fourth heart sound will be between this A to B. Okay. Now, this discussion is done. Now, we can easily point out the answer. That question is, when does the first heart sound occur? So, obviously at point number B is the answer. So, option A is the answer of this question. ठीक है? Ejection fraction calculation you have done, and cardiac output calculation can also be done from this question, because you know that heart rate has been given here. So, you have to find out the stroke volume from this PV loop. How can you calculate the stroke volume? So, this is your end diastolic volume and this is your end systolic volume. So, the difference between these two volume is the stroke volume, that is the 150 minus 50, that is 100 ml is the stroke volume. So, here in this diagram stroke volume will be the 100 ml, and if you multiply this stroke volume into the heartbeat, then you can get the cardiac output also. Okay, very good. So, this kind of question can be given. What is happening? Okay, chalo, next. Okay, so that discussion is done. Now, you look at this question. So, this question is a little difficult question. Okay, try to look at it. This is the graph which I have taken from Genongs. Okay. Cardiac response to moderate exercise. Okay, and parallelly they have recorded the response from the normal person and transplanted heart person. So, transplanted heart person means the sympathetic parasympathetic nervous system is disconnected from the heart. That is the thing, na? Because whenever you are cutting out the heart from the body, sympathetic parasympathetic obviously have to disconnect, and then you are transplanting that heart into a different person. Okay. So, sympathetic parasympathetic system है नहीं, तो हार्ट रेट कैसे चेंज होगा? हार्ट रेट बढ़ेगा नहीं, बिकॉज सिंपैथेटिक सिस्टम के थ्रू ही तो हार्ट रेट बढ़ता है एक्सरसाइज के टाइम. ठीक है, बट इफ यू लुक एट दिस डायग्राम केयरफुली, okay, what I have to look at the first one, oxygen consumption. Whenever a person is doing exercise, the oxygen consumption will increase more and more, because muscle will consume more oxygen. So, that is why I am looking at here the oxygen consumption is rising and then the plateau, and whenever exercise is terminated, oxygen consumption is decreased. Same way, the transplanted person is also using the same amount of similar amount of oxygen, means oxygen consumption there is no difference between these two. Okay. So, I should not write no, I should write no difference, no difference. Okay. Then if I look at the second curve, cardiac output increment is happening in both the person, transplanted heart and normal person. Again I am finding out no difference between these two. Now, we all know that cardiac output is the multiplication product of the stroke volume multiplied by heart rate, just now we have discussed. So, in a normal person, when a normal person is doing exercise, okay, how the heart rate will increase or change, and how the stroke volume will increase or change in a normal person. Look at this curve. So, whenever a person is doing exercise, so suppose the x axis is the exercise, different grades of exercise. grades of exercise, different grades of exercise. मान लो mild exercise, moderate exercise, severe exercise. Okay. And y axis may be heart rate, may be stroke volume. So, normal person, whenever a person is doing exercise, the heart rate will increase gradually like this, okay, until and unless it is reaching to a maximum level. मैक्सिमम लेवल तक पहुंच जाएगा एंड मैक्सिमम हार्ट रेट कितना अचीव हो सकता है 220 माइनस एज ऑफ द पर्सन मीन्स इफ माई एज इज 45 years, so 220 minus 45, that is the maximum heart rate that I can achieved with maximum strength of exercise, severe exercise. उसके ज़्यादा जाएगा ही नहीं. So means obviously you can understand that younger the person, heart rate reserve is more, means he or she can increase their heart rate to a very high level. Okay. So because formula is maximum heart rate is equal to 220 minus age of the person, age in year, right? Okay. So this increase in heart rate is because of the sympathetic stimulation and parasympathetic inhibition. Sympathetic stimulation and parasympathetic inhibition. ठीक है, कोई दिक्कत नहीं. Okay. And if you look at the stroke volume, the stroke volume curve will be like this. There will be a plateau. So this is the stroke volume, okay, of a normal person. Means initially when the person is increasing the strength of exercise, the stroke volume will go on increasing, but later on stroke volume will plateau. Why stroke volume will plateau? So if I go on increasing the strength of my exercise, what will happen? The venous return will increase. More the venous return, the heart will stretch more, means endostolic volume will be more, and more the endostolic volume means the heart will contract more forcefully because of the Frank-Starling law. What are those Frank-Starling law? Frank-Starling law says that whenever you stretch the ventricular muscle more and more, the ventricle will contract more forcefully. So, I am doing exercise, more venous return is coming to heart, the endostolic volume is increased, heart is producing more forcefully, that is Frank-Starling law. So, what will happen to stroke volume? Stroke volume will increase, but how long? Heart has a capacity to stretch. How much blood it can stretch is at the maximum limit. That's why if you go on increasing the strength of exercise gradually, the stroke volume will increase gradually initially, but later on the stroke volume will plateau. That means after this point, beyond this point, the heart cannot stretch more, the endostolic volume cannot be increased, right. So, this is the curve taken from normal person. Now, if a person is having transplanted heart, okay, transplanted heart. So, what do you think, the heart rate of this person will be increased during exercise or not? Normally, if you think, then you will look at here that sympathetic parasympathetic stimulation, parasympathetic inhibition, this is the cause of increased heart rate in normal person. But in transplanted heart, sympathetic parasympathetic is not there, so heart rate should not change. But think once again, you have disconnected the sympathetic parasympathetic system from heart, but sympathetic and parasympathetic system is there in the other part of the body. So, whenever this transplanted heart person is doing exercise, sympathetic system will be activated, not the heart I am talking about, sympathetic system of the other part of the body will be activated. It will reach at the level of the adrenal medulla, and from the level of the adrenal medulla it is going to secrete epinephrine and norepinephrine, and now this epinephrine and norepinephrine is going to act on the beta 1 receptor on the heart muscles, and this beta 1 receptor stimulation will increase the heart rate. Getting my point? So, you have disconnected the sympathetic and parasympathetic system of the transplanted heart, but the receptors are present on the cell surface, the membrane on the membrane of the muscles. So, these receptors are still intact, and this receptor can be activated by circulating epinephrine and norepinephrine. And where from this circulating epinephrine and norepinephrine is coming? The circulating epinephrine and norepinephrine is coming from adrenal medulla. So, whenever the person is doing exercise with a transplanted heart, first of all sympathetic parasympathetic system will stimulate the adrenal medulla, and then epinephrine norepinephrine will enter in the circulation, and then it will reach to the heart, and then it will increase the heart rate. That means this increase in heart rate will not be very steeper like that of a normal person. The heart rate increment will be very gradual and slow heart rate increment. Getting my point? Okay. So, whenever a person with a transplanted heart is doing exercise, heart rate will increase because of the circulating epinephrine and norepinephrine from adrenal medulla, not by the sympathetic and parasympathetic system. And the stroke volume will also increase. How the stroke volume will increase? Because of the application of the Frank-Starling law. Frank-Starling law, stretch the muscle, muscle will contract more forcefully. This is the endogenous mechanism within the muscle. This is not related to the sympathetic parasympathetic system. So, Frank-Starling law is operational in transplanted heart, and beta 1 receptor is intact on the muscle membrane. So, beta 1 receptor will be stimulated by circulating catecholamines, gradual heart rate increment will be there, and Frank-Starling law operation is still there. So, obviously the stroke volume is going to increase. So, now if you look at the graph once again, so here you can clearly differentiate that heart rate increment in normal person is very steeper, this portion, but heart rate increment in transplanted heart is gradual. Okay. And stroke volume increment in normal person, stroke volume increment in normal person is gradual, because I told you that there is a limit, but in case of transplanted heart, this Frank-Starling law is strongly operational at the beginning point. So, that is why the stroke volume is increasing steeply in case of transplanted heart, but in normal person this is gradually operational. This operation is slow, okay, because the sympathetic and parasympathetic is there. Okay. So, that is why in case of transplanted heart, if I ask you what is the cause of this increase in cardiac output like normal person, your answer will be stroke volume increment is very steeper and heart rate increment is very slower. But if I ask you for a normal person, what is the cause of increased heart rate, increased cardiac output, your answer will be mainly the stiffer increase in heart rate followed by gradual increase in stroke volume. Getting my point? So, this is the difference that you have to remember, that normal person means my cardiac output will increase during exercise, okay, but this increment is because of the stroke volume and heart rate, but in the later half of the exercise means during this portion the increment of cardiac output is only because of the increment of heart rate. So, initially both will contribute, but later on only the heart rate increment will contribute to the increase in cardiac output. But in case of transplanted heart, okay, heart rate contribution is lesser because that is increased by circulating epinephrine, norepinephrine, and stroke volume increment is mainly contributed by Frank-Starling law. So, whatever I have discussed, everything has been written here. You can read it here later on, so that you can revise it very quickly. Now, if I go back to the question here, so question is cardiac response, the slow rise of heart rate. Question is telling you everything, that the rise of heart rate is slow in case of transplanted heart, and what is the cause of this increment of the heart rate. So, sympathetic innervation is not there, Bainbridge reflex is not there, Andref is not there, circulating catecholamines from adrenal medulla is the answer of this choice. Got it, everybody? So, this is the answer of this question, and this understanding is very essential. Okay. Okay. Now, we are moving on to the next question. Okay. So, again this is a repeat MCQ, previous year MCQ. So, intestinal muscle was isolated, electrical mechanical stimulation. So, this is an easy question. So, if you look at this diagram, बोलो आंसर बताते जाओ. So, this is basically the BER. Okay. This is basically your BER. This is basically your BER, basal electrical rhythm. Okay. Onto the surface of this basal electrical rhythm, you are getting few spike potential. So, these spike potential are nothing but the kind of action potential. So, this is nothing but a kind of action potential. And whenever action potential appears on the surface of the BER, it causes contraction of the intestinal smooth muscle. And whenever the intestinal smooth muscle is contracting, the tension will rise in the muscle. So, lower part of this recording here, see, this is the mechanical recording, that is the tension generated by the smooth muscle, and upper part is the electrical recording. Okay. So, from these two recording, look at here, the tension is increasing. Why the tension is increasing? This is proportionate to the spike potential frequency. Here also the tension is increasing, but the tension is little lesser than the first one, because the frequency of the spike potential has reduced. In the first diagram 3 spike potential, but here only 1 spike potential, and again here the 3 spike potential, the tension is rising more. So, more the spike potential frequency, more will be the tension in the muscle, more will be the tension in the muscle. So, this is the main thing that you have to remember from here. So, now if you look at the options, tension developed proportional to the frequency of the spike potential. This is absolutely true statement. Tension developed directly proportional to the amplitude. It is not proportional to the amplitude, it is only proportional to the frequency. Option C, threshold voltage is minus 50. So, if you look at this B here, so this is the basal electrical rhythm which is going on. Okay. So, basal electrical rhythm, whenever it is crossing this minus 50 millivolt, then and then only the spike potential is appearing. That means this minus 55 millivolt, this is the threshold voltage. So, okay. So, threshold voltage is minus 50, this is also true, and frequency is around 6 per minute. So, if I look at the x axis of this diagram, so this is 10 second, within the 10 second I am getting only 1 BER. So, within 10 second I am getting only 1 BER, that means per minute, how much is the rate? 6 per minute. Okay. So, BER rate is 6 per minute, this is also true. So, you have to find out the false statement. Option B is the false statement. So, answer is option B in this question. Okay. So, I believe repeat question. So, you are already prepared to tackle this kind of question. Okay. Now, along with this also look at this image. Again this is same image, similar kind of image from Genong. Okay. So, I will describe this image quickly. So, this is basically your BER is going on, this is basically your BER is going on, and on the surface of this BER you are getting this spike, you are getting this spike. Okay. So, spike is appearing in presence of cholinergic stimulation. So, whenever you give acetylcholine on the intestinal smooth muscle, the muscle is activated, it will produce spike potential, and whenever the spike is there, the muscle will contract. So, there will be contraction of the muscle, and because of the contraction tension is generated. But all of you know that rather than acetylcholine, if you give epinephrine and norepinephrine to the intestinal muscle, so what is happening? This spike potential is disappearing, spike potential is disappearing. Okay. And because of the disappearance of the spike potential, there will be relaxation of the muscle, and relaxation means tension will decrease like this, tension will decrease like this. Okay. So, this thing you have to remember. Now, based on this, another MCQ is here. This is again a old question of INI-CET, but I believe this kind of question can also be given in NEET. Okay. Look at here. So, a small segment of the mammalian small intestine was mounted over Dell's apparatus. So, this apparatus is nothing but this is an experimental chamber where the intestinal movement is recorded. So, you do not have to think of the Dell's apparatus much, but what is given in this question that the movement of the intestine was recorded. So, if you follow this curve, so intestine is contracting, relaxing, that means this upward direction is the contraction of the intestine, okay, and this downward direction is the relaxation of the intestine, right. Now, whenever you are giving this drug X, the intestinal contraction and relaxation is decreasing gradually, and then there is complete relaxation, of the intestine. So, we all know, just now we have discussed that if we give epinephrine or norepinephrine to the intestinal smooth muscle, it causes relaxation because of the disappearance of the spike potential, because of the decrease in the membrane potential. So, the answer of this question will be adrenaline. Okay. All other stimulus that is given here, all of them causes increased contraction. So, acetylcholine, it increases the contraction of the intestine. Okay. Barium chloride and calcium chloride, they also increases the contraction of the intestinal smooth muscle. So, only adrenal causes decreased contraction of the intestinal smooth muscle. Got it? So, these two questions already been asked from GIT. Now, another image which is also there in Genong, concept is same, but you have to prepare that image may be different. Okay. Now, if you look at this image, so this is a new image to you, but I believe I have discussed this image in some of the other classes also. So, here minus 50 millivolt is the RMP like scenario. So, this is the RMP like scenario. So, I can understand the image A is showing that RMP is crossing the threshold voltage. So, this is the threshold, this is the threshold. Okay. So, whenever the RMP is crossing the threshold voltage, these are the spike potential, spike potential. So, A means the spike potential is appearing. So, what will be the stimulus for this? Acetylcholine. But if you look at the curve B is showing that resting membrane potential is going in the more negative direction, means there is hyperpolarization of the resting membrane potential. So, hyperpolarization of the resting membrane potential is B. Hyperpolarization of the resting membrane potential is done by adrenaline. Okay. So, the answer of this question will be adrenaline. All of the other stimulus which is given here, including the cold and acetylcholine, they will causes depolarization of the membrane voltage followed by spike potential, spike potential. So, this you have to remember that cold stimulus, acetylcholine, calcium chloride, barium chloride, all of them causes depolarization of the smooth muscle membrane voltage followed by spike potential whenever the depolarization is crossing the threshold. Got it? So, the answer of this question is option D. Got it? Okay. Chalo. So, this whatever I have discussed is written here. So, you can read it later on for your revision purpose. Okay. Next question. Again a repeat question, previous year question. So, you all know the answer that in cystometrogram there is a flat portion. This flat portion indicate that pressure is not rising, and this is typical application of which law? This is typical application of Laplace law. Okay. Because you all know that Laplace law is saying that if this is your urinary bladder, okay, if this is your urinary bladder, P is the pressure inside this urinary bladder, intravesical pressure, okay, and T is the tension generated at the muscles here. So, T is the tension here, okay, tension generated on this muscle of the bladder. We all know Laplace law is saying P is equal to twice T upon R. So, whenever urine is filling the urinary bladder, so more and more urine is coming into the bladder, urine is coming into the bladder, more and more urine. So, more the urine is coming, the tension in the bladder wall will be increased, proportionally the bladder will be stretched, means radius will also increase, the diameter will increase. So, because both the tension in the wall is rising and radius is also rising, the pressure, intravesicular pressure will remain same, and that is depicted by 1b portion. This is typical application of law of Laplace. Okay. Yes. So, we generally ask that at which volume in the bladder the first urge to void, so your urinary bladder is filling. Whenever the volume of the urinary bladder is near equal to 150 ml, you will get first urge to void, but you can suppress that urge. But whenever the urinary bladder volume is 400, that is a strong urge, you cannot hold it, the micturition reflex will start, and because of the micturition reflex starting, suddenly there will be increase in pressure within the urinary bladder and micturition will happen. So, question is, if the question is first urge to void the urine, first urge, that is 150 ml, but you can suppress that urge, okay. But whenever it is 400 or beyond, that will produce strong urge, you cannot prevent that. After some certain point of time, the micturition reflex will start automatically, and that will causes voiding of the urine, okay. So, this thing you have to remember, okay. Now, next question, the percentage of the filter load of different substances in different part of the nephron. So, this is an easier question, again a repeat question. So, x axis different segment of the neuron. So, Bowman space, proximal tubule, distal tubule and urine. So, you can imagine a diagram like this, that this is the Bowman's capsule followed by proximal tubule, and then you are reaching the different part, okay, reaching the different part. This is the urinary bladder, okay. So, whenever there is filtration at the level of the Bowman's capsule, whenever there is filtration at the level of this Bowman's capsule, this is your 100%. Any substances which is filtered at the level of Bowman's capsule, that is equal to your 100%. Now, from this filtration point at the level of the Bowman's capsule, if you follow this curve number D, the concentration of the substances is increasing inside this nephron, different parts. Concentration is gradually increasing, particularly within this proximal segment, the concentration is rising, followed by concentration is fixed. So, obviously, there must be secretion of these substances into the nephron. So, there must be secretion Okay. So, this is typical of substances which is hugely secreted in the nephron, and that is para-aminohippuric acid. So, answer of this question is para-aminohippuric acid. Creatinine is also secreted in the nephron, but that secretion is a little lesser than this. So, this is the typical curve of creatinine secretion. Now, if you look at the green color curve, this green color curve is a straight line. That means, if you follow the concentration of these substances throughout the nephron, concentration is not changing. That means, no secretion, no secretion, no reabsorption, no reabsorption, and this is typically of inulin, right? This is typically of inulin, all of you know, okay? Yes, very good. This option B you can understand that there is reabsorption, but ultimately certain amount is excreted in the urine. So, option B, it can be bicarbonate also, it can be sodium also, it can be potassium also, because certain portion is absorbed and certain portion is excreted in the urine, but excretion in the urine is very, very less. But if I look at A means the concentration is decreasing to a 0 level within this proximal tubule only. That means 100% reabsorption within proximal tubule. So, this must be glucose or this must be amino acid. Very good, very good. Okay. So, this is answer is option number A. Great. So, your preparation is going on. Now, you answer this question. I believe you will be able to answer. So, all of you know that normal spirometer, if it is given, then this is the tidal volume. Okay. This is the tidal volume. Apart from tidal volume, the extra amount of air which you can take it is the inspiratory reserve volume. Very good. And the excess amount of air that you can expire, this is expiratory reserve volume. And apart from that, one volume which cannot be measured beyond this point, that is residual volume. So, this green color curve which is given in this question, okay. So, this green color arrow, this is the combination of residual volume plus ERV, expiratory reserve volume, and combination of these two is known as the functional residual capacity. So, answer is FRC. Getting my point? So, 24 this question is option number B, FRC is the answer. All of you have given correct answer. Very good. Chalo. Okay. Next question. Again, this is a question which is my favorite. Okay. And this question has been asked, but in a different way. They gave you this different normal curve, compliance curve, and this one and this one. They previously asked you to identify that this higher curve is because of the which disease. So, this is emphysema and low compliance is fibrosis. But here in this question, they have asked you to calculate the compliance of the normal person. So, this normal compliance curve, okay, from here you have to calculate the compliance. So, how to do that? In my previous session, I have discussed that first of all, you have to drop one perpendicular from any point on the y axis. So, from this 5 liter point, I am dropping on perpendicular on this normal curve. Okay. Look at what I have done. So, I have dropped one perpendicular on this curve. Okay. So, here I should take the red color. So, here is the point. Okay. So, what I have done, I have dropped this perpendicular from this 5 liter point on x, and then I am extending this perpendicular on x axis. Okay, x axis. Okay. Now, again I will take another point. So, I will take a different color, scale ले लिया, scale लेके from the 3 liter point, or maybe from the 4 liter point I can also do. I have dropped this perpendicular here on this curve, and from that point I am dropping the perpendicular on x axis. Okay. Now, job is done. So, 5 liter, 3 liter, from this 2 point I have dropped 2 perpendicular on this normal compliance curve, and then I have extended those perpendicular onto the x axis. So, in x axis it is cutting at 2 point. So, this is 1 point, this is 1 point. So, the distance between these 2 point, this is nothing but, okay, delta P. Why delta P? Because x axis is what? X axis is the pressure, transpulmonary pressure. So, the difference between these 2 point here and here, this is my delta P. this is my delta P. And if you look at the scale, this delta P is almost 10, a little lesser, but it is almost 10 centimeter of water. Okay. And the difference between this 2 point on y axis, this difference, this is nothing but my delta V. Okay. So, in this cases delta V is from 3 to 5 means 2 liter. So, basically delta V is 2 liter and delta P is 10 centimeter of water. So, obvious thing is that compliance is delta V upon delta P. So, 2 liter means 2000 ml upon 10. So, obviously this will be 200 ml per centimeter of water, answer B. Okay. Very good. Okay. So, एक बार check कर लो. Please look at the curve in the exam very carefully. Here it is coming around 200 ml per centimeter of water, but some of the curve may be a little lesser than this. So, be careful in the exam. So, V delta V upon delta P, if you do it, you will be able to answer. Okay. Done. Okay. Next question. Again, two very favorite question of mine. Okay. And this kind of question has been repeated. So, here two question parallelly I will show. So, this is the first question. Here the question is in y axis oxygen saturation and in x axis partial pressure. So, this is basically oxygen hemoglobin dissociation curve. Two things you have to note down from here. One is that arterial blood question is asking and the person is severely anemic. So, arterial blood means what is the partial pressure of oxygen? So, partial pressure of oxygen in x axis. So, partial pressure of oxygen is 100 millimeter of mercury. Anemic person means partial pressure of oxygen is not going to change. So, now if I drop a perpendicular from this 100 millimeter of mercury point, I have to choose between this option D or option E. One will be the answer of this question. One will be the answer of this question between this E or point D, that this is the anemic person. So, in case of anemic person, the partial pressure of arterial blood oxygen is normal and the saturation is also normal. Saturation also normal means how much will be the saturation? The saturation will be near equal to 97-98 millimeter of mercury, means this point number D is the anemic person here. Okay. So, answer is point number D in this question. Anemic person. Okay. Please remember, anemic person means partial pressure of oxygen in the blood is normal and saturation of the hemoglobin is also normal. But the problem is total amount of hemoglobin is less. That is the main problem. So, the oxygen content will be lesser, but not the saturation of the hemoglobin. Hemoglobin will be saturated with equal normal amount of oxygen, but the total amount of hemoglobin is less. So, the content of the oxygen will be less in the blood. So, similar way, if I show you the next question, in the next question the curve is exactly same curve. Okay. So, again I have to find out a point at 100 millimeter of mercury between this D and E. But now if I look at the y axis, the y axis is the content of oxygen, content in ml, oxygen content. So, just now I told you that oxygen content, okay, in normal person in the arterial blood is how much? 20 ml per deciliter of blood. So, if you look at the number of the y axis, that is also change here. Number of the y axis को देखो, number देखो यहाँ पे 20, 15, 10. But in the previous diagram, what is the number? 100. This is the saturation. 100, 50, 75. So, saturation remain normal in anemic person, but the oxygen content will definitely decrease because hemoglobin amount is less. So, in these cases the normal oxygen content is 20 ml. So, option D, the point number D, this is for the normal person, this is for the normal person, and point number E is the anemic person. Point number E is the anemic person. So, arterial blood oxygen content will severely decrease and point number E will be the answer in this question. Tricky question, very similar graph, but if you do not look at the y axis, you are going to make a mistake. Okay. Please look at the y axis. So, what is the bottom line? Bottom line is that oxygen content will be lesser than normal, but saturation partial pressure will be same to same with that of the normal person in case of anemic person. That is the bottom line, that is the take home message. All done? Okay. Chalo. Next question, few questions are remaining. Okay. So, one transport system across the cell membrane is given below. So, very easy question. repeat question from NEET. So, here I can see that this is the transporter protein which is changing its shape. First it was open in the outer surface, then it is attached with the substances, then after attachment with the substances the transporter protein, the carrier protein is changing its shape and then it is releasing the substances on the other hand side. So, carrier mediated transport. Now, the carrier mediated transport can be active, can be passive. How to identify it? That this carrier mediated transport. So, if you look at this image, this is nothing but the carrier mediated transport. Now, the carrier mediated transport can be active also, okay, primary or secondary, it can be passive also. Passive means it will be facilitated diffusion, active means this is primary or secondary active transport. Now, I am looking at this molecule, number of the molecule. So, number of the molecule is here, this is very huge in number, and this side maybe this is suppose extracellular surface, extracellular fluid, and this is the intracellular fluid. So, extracellular fluid contain huge concentration of the substances and substance is moving from ECF to ICF down the concentration gradient or along the concentration gradient, not in the opposite direction. So, whenever substance moves along the concentration gradient or in the downhill direction, that means that it is a kind of passive transport. So, indicate that it is a passive carrier mediated transport. Passive carrier mediated transport is only the facilitated diffusion. Simple diffusion does not require carrier protein, okay. And secondary and primary, both of them are the active kind of transport. So, active kind of transport means there will be uphill kind of transport, uphill kind of transport will be there, okay. So, this you have to remember and you will be able to answer, okay. So, this is done. I believe you got the answer, 28 slide number. Now, the next one. So, again this is a, I mean 2-3 years ago this question was asked in NEET exam and this was a diagram exactly taken from Guyton, okay, exactly taken from Guyton. So, here you have to understand this graph is a little difficult. So, if you have already read the answer, so you know the answer that what will be the answer, but look at, try to understand the curve, okay. So, x axis is the time and y axis is the body temperature. Now, two curve has been given, one is the setting of the thermostat and second one is the actual body temperature. I will say and try to understand. So, first of all if I ask you that thermoregulatory center कहाँ पे located है, बोलो आंसर बताओ. Thermoregulatory center, thermoregulatory center हमारा ब्रेन में कहाँ पे लोकेटेड है? Your answer will be hypothalamus. Your answer will be hypothalamus. At the level of the hypothalamic thermoregulatory center, there is a set point. There is a set point at the level of the hypothalamus, and this set point is located on the preoptic nucleus of hypothalamus. Preoptic nucleus of hypothalamus, right. So, these two things you have to remember. Separate MCQ can be given that thermoregulatory center कहाँ पे located होता है and set point कहाँ पे located. Set point in the preoptic nucleus. Set point means it will decide that what should be your core body temperature. So, your environmental temperature may change. Depending on the environmental temperature, the set point may also change, but hypothalamus will decide that how much will be the set point. Now, what happens during certain pathological condition, like for example, suppose a person is suffering from fever. So, you know the pyrogens. So, pyrogens will increase the set point of the hypothalamus. So, what I am saying that pyrogens will increase the set point of the hypothalamus. Whenever pyrogens are increasing the set point, what happens? The set point will suddenly raise to a higher level. So, look at this highlighted portion, this is the set point changes. So, normally this is the normal portion, this is the normal body temperature, and our normal body temperature is how much? We know 98.6 degree Fahrenheit. So, this 98 and this is approximately 98.6 degree Fahrenheit. So, this is the normal, this is the normal. Now, the pyrogens is attacking the set point of the hypothalamus. Because of the pyrogen attacks, what is happening? The set point is suddenly raised to a higher level. What is the set point now? The set point is set at 103 degree Fahrenheit. So, hypothalamus is instructing that the set point is very high level, that is 103 degree Fahrenheit, but body temperature is still at 98.6 degree. Okay, body temperature is still at 98 and set point is high. So, set point high ho gaya, body temperature low. So, what will be the feeling inside your body? Your body will feel as it very cold. Okay. That is why at the beginning of the fever you feel chills and cold, okay, because set point is suddenly raised by pyrogens, okay, and body temperature is still at low point, right. See, chill, first chill hoga. Now the body temperature has to match the set point because hypothalamus is a commanding center. He is saying that set point should be 103 degree Fahrenheit, body temperature is still at 98. So, body temperature has to increase to match the set point. How the body temperature will increase? By shivering. Whenever the muscle is contracting, the muscle will produce heat. That heat will increase the body temperature. Okay, curling of the body, you are conserving the heat inside the body. Horripilation, the hair follicles will be raised, they will trap some air. So, all these things, the shivering, the horripilation, the piloreaction, all of these things will increase the body temperature. But do you think this increased body temperature will be suddenly raised to a high level? Answer, no. That is why because of this vasoconstriction, because of this piloreaction, because of this epinephrine secretion, because of this shivering, the body temperature will rise, it will match the set point, but it will take some time. That is why the body temperature is gradually rising to match the set point, and this time, this is the time where you are going to feel the cold sensation, the chill sensation, and that is why at the initial part when the fever is coming, we feel chills and rigor. Why? So, this rigor is shivering and this chill is because the set point is higher, but your body is still cold. Okay. Now, whenever your set point is matching the whenever your set point is matching the core body temperature, like for example here this part, now the fever is there, your core body temperature is also 103 degree centigrade and set point is also 1 degree centigrade. So, at this point you are not going to feel cold. Now, the chill feeling will gone, but the fever is there. If you measure with thermometer, you will get higher body temperature. Okay. Now, suppose you have given some paracetamols, or suppose this pyrogens is washed away from the blood, washed away from the hypothalamus. So, whenever the pyrogens are washed away, the set point will suddenly lower down. So, now suppose because of the drug effect, the pyrogens are lower down. So, what will happen? Suddenly the set point will also decrease. Now, this is the part where the set point is showing sudden lowering down. Now, you think of your body temperature is still at 103 degree Fahrenheit, but the hypothalamus has instructed that body temperature should be lowered down. Now, what will you feel? You will feel that your core body is huge than that of the set point. Now, you are going to feel the hot sensation. This is known as the flushing reaction or crisis reaction. That is why we say that when the fever is going away from your body, you will feel that as if your body is hugely heated. Why? Because your body has gained heat already because of this vasoconstriction, horripilation, everything. But now the set point is suddenly lower down and your body is still at 103 degree Fahrenheit. So, you will feel very hot. That is known as the flushing reaction or crisis reaction at the end of the fever. Now, what the body has to do? Body has to command this set point. Okay. So, now the body temperature has to decrease to the set point level, but the body temperature decrement again it will follow a slow curve. That is why you can find out here that the body temperature is decreasing, but gradual decrease in body temperature. And how the body temperature will decrease? By losing the heat from the body. How you are going to lose the heat from the body? By vasodilation, by sweating. Getting my point? So, this is the explanation of this curve. Now, you look at the question. So, question is, which change will be seen at A as compared to B? So, this A they are asking that what will happen at point number A in comparison to point number B. So, we all know that A means the body is gaining heat. The body is gaining heat. How the body will gain heat? By shivering, okay, by shivering. So, the shivering will be the answer. All other options which are given here, sweating, increased blood flow to the skin, shutdown of the chemical thermoregulation, all of them will happen at point number B, that is the heat loss mechanism. Got it? Okay. So, the answer of this question is option number C. Okay. Okay, chalo. Got it na everybody? Or got the explanation समझ में आ गया? Important. Okay. Next question. Again very simple question. Now, preoptic nucleus is a part of the anterior hypothalamus. Okay. The preoptic nucleus will communicate with the posterior hypothalamic nucleus, that is known as the severing center. Preoptic nucleus is a part of the anterior hypothalamus. So, you can say anterior hypothalamus, posterior hypothalamus. So, we generally say that anterior hypothalamus will respond, posterior hypothalamus will respond to cold and anterior will respond to hot. But here what happens, this anterior hypothalamic nucleus is the preoptic nucleus where the set point is located. So, this is not the normal thermoregulatory system. This is the pathological scenario where preoptic nucleus is activated by the pyrogens. Okay. So, whatever you are saying anterior and posterior hypothalamus, so this preoptic nucleus is a part of the anterior hypothalamus. So, that is the main center. It will communicate with the posterior hypothalamus when you require severing. Okay. Okay. Next question. So, this question, okay, which of the following? So, you can easily answer. So, this is one cell, this is another cell. So, this cell is secreting substances and this substances is reaching to the nearby cell by the process of diffusion. So, whenever one cell is secreting substances and reaching to the nearby cell by the process of diffusion, we know this is known as a paracrine type of secretion. So, easy question, easy answer, paracrine secretion. I believe all of you know the meaning of this. So, endocrine, autocrine, paracrine. So, paracrine means when the secretion is going to the nearby cell by the process of diffusion, and juxtacrine is similar, but I have explained in multiple classes the juxtacrine. Two cells are interacting with one another, but those cells are very close with one another, because of which they are touching with one another, right. And autocrine means, from the name you can easily understand that the product is acting on the same cell, okay. And endocrine means through the blood vessel the substance will move from one part to other part, okay. So, this is typical force cell signaling thing, you know, okay. Now, next last two questions. So, these two questions are again from previous year. This is a very famous curve from Guyton, okay. You can easily identify. So, I can find out here the hormone level is fluctuating throughout the day, This kind of hormonal fluctuation throughout the day is known as the pulsatile secretion of hormone. There are many hormones which has pulsatile nature of secretion, but here this is typically, this is growth hormone. Why? Because this exercise is a strong stimulus for growth hormone, and the sleep, the non-REM stage of the sleep, is also a strong stimulus for growth hormone secretion. So, pulsatile in nature, sleep is a stimulus and strenuous exercise is a stimulus for growth hormone. Apart from that, you have to remember hypoglycemia is also a strong stimulus. Hypoglycemia is also a strong stimulus for growth hormone. So, the answer of this question is growth hormone, but these three main stimulus you have to remember, okay. And because the growth hormone secretion is pulsatile in nature, you know that whenever you want to diagnose acromegaly, so we know that acromegaly means growth hormone level will be high, but you cannot measure growth hormone from an acromegaly patient, because you know that throughout the day it is giving you pulsatile secretion. So, suppose you are measuring the growth hormone from an acromegaly patient from this time point. So, you will get a huge level of growth hormone in the acromegaly patient, and if you are measuring the growth hormone level from acromegaly patient from this point, you are going to get a lower value. So, simple measuring the growth hormone in acromegaly patient is not diagnostic, but we say that first you give a glucose load to the acromegaly patient, 75 gram glucose, and then after giving glucose load you measure the growth hormone. If the glucose load is suppressing the growth hormone level, then it is a normal phenomena, but if that glucose load is not suppressing the growth hormone level, then it is acromegaly, because just now I told you that hypoglycemia is a stimulus for growth hormone secretion. Whenever you give glucose load, it is supposed to suppress the growth hormone level, but if it is not suppressed, then that is a diagnostic of acromegaly. That you have to remember, that because of this pulsatile nature, growth hormone cannot be measured directly. You have to give glucose load followed by growth hormone measurement. Okay, okay, chalo. Last one, Hormonal profile study of an adult, this is again a repeat question. So, we are finding out that this is the sleep period, means this is the onset of sleep, this is the onset of sleep. So, after the onset of sleep, when the person is waking in the morning, waking up in the morning, so this is in the morning time you are getting the peak secretion of this hormone, and during the night time you are getting lowest value during the night time. So, this is typical of diurnal secretion of hormone, and diurnal secretion is followed by ACTH hormone, and because ACTH follow the diurnal secretion, the cortisol will also follow diurnal variation. So, the answer of this question will be cortisol. Okay. So, maximum secretion in the morning 8:30 am in the morning, and minimum secretion in the midnight, almost 12 p.m. Midnight in the night. So, that is the diurnal variation of ACTH and cortisol both. Okay. So, yes, very good. So, this is all about the image based discussion of physiology. Most of the important images I have discussed, I have checked the previous year questions. So, I have taken some of the previous year questions and some of the new questions. So, I believe this will be helpful for you. So, after 1 hour you are going to get the PDF of this session. So, please download the PDF from the YouTube chat link, it will be given there, and give a quick revision before your exam. So, because these are the important images which you may get a question in your NEET exam and obviously in the FMGE exam also. So, thank you so much. Bye bye. Take care.